Hello everyone, my name is Spencer Grazak, and I am the PGY2 Emergency Medicine Pharmacy Resident at Detroit Receiving Hospital. I had the opportunity to work with emergency physician and toxicologist Dr. Andrew King and emergency medicine pharmacy specialist Drs. Rachel Wine and Casey Mangan. Our research project focuses on buprenorphine induction in the emergency department for opioid use disorder and its effect on subsequent ED visit rates. The opioid epidemic continues to worsen each year in the United States. Hundreds of thousands of ED visits each year are due to opioid use disorder. And because of this, it is important to continuously seek ways to help our patients with opioid use disorder. Buprenorphine is one of the most safe and effective therapies for the treatment of opioid use disorder in preventing overdose and death. Buprenorphine offers advantages as a partial mu opioid agonist, resulting in decreased risk of misuse and respiratory depression. At Detroit Medical Center, a program to identify, treat, and refer opioid use disorder patients from the emergency department was created and initiated in November of 2019. This was a retrospective cohort study, including adult patients with opioid use disorder who were treated with buprenorphine in the ED. One cohort of patients acted as their own control group. The first step was to identify an index ED visit, which was the initial buprenorphine induction in the ED between November of 2020 and March of 2022. We took that group of identified patients, and the comparison groups were 6 months before and 6 months after that index ED visit. The primary outcome we assessed was the incidence of ED visits for opioid use disorder, notably breaking this down further into the specific visit reason, whether it be opioid overdose, withdrawal, or seeking buprenorphine refills. We also conducted subgroup analysis for patients who refilled buprenorphine and those who received greater than 8 milligrams per day of buprenorphine during their index ED visit. Moving forward with results, 51 patients met inclusion criteria, majority of which were middle-aged African American men. During the index visit, about half received a buprenorphine prescription at discharge, and the median daily dose of buprenorphine administered was 8 milligrams. As for the primary outcome, Figure 1 compares the number of ED visits before versus after buprenorphine induction in the ED. On the y-axis, we have the total number of ED visits in a 6-month time period, and on the x-axis, we have the breakdown of the reason for the ED visit related to opioid use disorder. The green bar indicates before, and the blue bar indicates after buprenorphine induction. Notably, there was an increase in the total number of ED visits before versus after, with 34 versus 66 visits. However, this increase in visits is primarily due to the increased trend in visits for buprenorphine refill requests, and you can see that on the far right column of this graph. There was a minimal change in the frequency of visits for opioid withdrawal and overdose. Moving forward to Figure 2, this is the first of 2 subgroup analyses I will discuss. The next 2 graphs have the same format, now with the y-axis indicating the change, or delta, in the number of ED visits before and after buprenorphine induction. This subgroup analysis looked at patients that refilled buprenorphine following the index visit, as in the green bar, versus those who did not, which is the blue bar. Those who refilled buprenorphine had a downwards trend of visits for withdrawal and an upward trend of visits for buprenorphine refills. Lastly, we go to Figure 3, which displays subgroup analysis between patients who received less than or equal to 8 milligrams of buprenorphine per day during their index ED visit, which is the green bar, versus greater than 8 milligrams per day, which is the blue bar. Those who received greater than 8 milligrams of buprenorphine per day had a decreased trend in visits due to opioid withdrawal, overdose, and an increased likelihood of returning for buprenorphine refills. Although there were no statistically significant differences, these results suggest that buprenorphine induction in the ED for opioid use disorder motivates patients to seek care, and we see that with that increase in ED visits for refill requests, rather than turning to opioid misuse. With the progression of opioid use disorder over time, particularly among the same cohort of patients, we would potentially expect to see an increase in the number of ED visits for withdrawal and overdose. Buprenorphine induction in the ED might have prevented this from occurring, as without access to buprenorphine, these visits or buprenorphine refills could have alternatively been for withdrawal or overdose. Among some group analysis, the daily dose of buprenorphine administered may have had an impact on the likelihood that patients continue with buprenorphine therapy. This can be seen in the increase in visits for buprenorphine refills. When higher doses of buprenorphine are used for induction, there was a decline trend of visits for opioid withdrawal and overdose. The reason for this might be due to higher patient satisfaction in the ED with buprenorphine due to less uncomfortable withdrawal effects, as well as preventing cravings. A few limitations of this study include the size of the study, as well as this cohort of patients were analyzed in 2 different time periods of the COVID-19 pandemic, which can affect ED visit rates. As for future directions of this study, I would like to focus on the potential barriers for our patients to obtain outpatient buprenorphine. Because of the increased rate in ED visits for buprenorphine refills, it raises the question why this refill cannot be obtained at a local retail pharmacy. Considerations can be cost, transportation, day supply, outpatient referral, appointment attendance, and more. Thank you all for your interest in this research project, and I will happily take any questions you might have at my email, which is sgrazak@dmc.org. Thank you all.